So without further ado, I'd like to introduce Cindy Carroll, who I met way back in the day as a dietetic nutrition student in Boston. And we both sat together in many classes, but I can remember Cindy fondly in our during our food science lab. So Cindy is a registered dietitian and a registered nurse who lives in Massachusetts, where she is the owner of the Institute for Functional Nutrition System Biology, which is an online educational and mentoring platform for nutrition health professionals. She also has had a private practice for over 25 years called Nutrition to Fit You. Cindy's career in healthcare covers quite a variety. She started out in dental hygiene from the University of Maryland, and in her early 20s decided to focus on nutrition at Simmons College in Boston. And then she obtained a postgraduate internship and graduate degree from Massachusetts General Hospital with a focus in sports nutrition. But that wasn't enough. Cindy decided to go back afterwards to receive an associate's degree in nursing, and she is a registered nurse as well. Cindy has worked in both organized medicine, Mass General Hospital and Harvard Pilgrim Healthcare Systems, as well as being a consultant for a variety of corporations, including Brio Systems and the US military. She has numerous publications, and her website includes www.ifn.health and www.nutritiontofityu.com. So without further ado, I'm going to move it over to Cindy.
Well, thank you, Katie, for that introduction. I'm really delighted to be here this evening with you and with Epicured and the great support staff that I've met in the last couple of days. And you guys offer such a great service, especially in such precarious times right now. So really such a timely service for now. And I hope all of you out there, as Katie had said, I hope you're all hanging in there and managing okay during this crazy time of the coronavirus. But glad we can communicate with you tonight with my webinar. So what I would like to do first, before I begin, is just to give you a little bit of an update on some offerings that I have coming up in the next couple of weeks and months. And it sort of reflects the talk that I'm going to give to you tonight too. And I just want to preface it by saying that I think we all learn information differently, complex information, certainly, medical nutrition information. And I realized for myself early on in my career that I sort of organized nutrition information according to the systems of the body. And I realized I did it early on. And then when I became a nurse, I sort of exclamation point that this is the way I think about the body. And so I have, it's helped me throughout my career and caring for my patients to be thinking this way, because I think it just organizes, complex information in a more methodical way. And so last year, I got a bit of a light bulb moment and decided to make a course about systems biology. And I offered it online, a live course twice, and it was pretty well received. And then I went to IFNCP in the fall, and I got such great sort of confirmation from many of you dietitians out there that this was a course that would be of interest to you. So I'm in the process now of taping it and have broadened it. And I'm aiming for it to be a certification in systems biology for nutrition, focused around nutrition. And it will probably be in the area of 20 credits or so, maybe 30 credits. And I'm aiming for the summer. So that's something to look forward to. And possibly we'll offer a live course as well, maybe once a year. And then in the short term, I have some handouts coming out that are similar to my course, kind of like a starter kit to get you in the mindset of thinking this way. And I hope my talk sort of does that too, to be thinking in terms of the systems of the body, because I think it's a bit of a mindset. You might think that it's obvious to be thinking this way, but we can get caught. So not that the food's not important, of course it is. And as food experts, we know so much about nutrients and foods, but it's just as important really to be able to have a good grasp of the anatomy and physiology so we can understand how the food applies to the body. So I have some assessment tools that are coming out in the next couple of weeks that will help you sort of grasp this information. Not as deep a dive as the course, but they're a good start, as well as a medical history tool that you'll be able to download and use yourself in your practice. And the key systems that I focus on are the GI tract, the cardiovascular system, the immune system, hormones, and the brain and central nervous system. And tonight, of course, we're going to take a little bit of a dive into the GI tract and cardiovascular system, so you'll get a little bit of snippet of some of the content of my course. And so here are just a couple of links for you if you are interested in getting on the waiting list for the course in the handouts, and there's my email address, and I'm happy to answer any questions at the end of the talk. So I do have just one disclosure. I have an affiliate relationship with the L Nutra company who sells the prolonged fasting mimicking diet, because I do sell that in my practice to certain patients. I have actually done it myself, and it is very relevant to this topic tonight, to cardiovascular health and also to the gut microbiome. So I'm going to talk just a little bit, not too much, but a little bit at the end of my talk, and I am happy to answer questions about that at the end. So here are my learning objectives. Describe the relationship between gut permeability, the gut microbiome, inflammation, and cardiovascular disease. Describe endotoxemia and its link to insulin resistance, type 2 diabetes, metabolic syndrome, fatty liver, and cardiovascular disease. State the significance of LPS as it relates to LDL cholesterol, inflammation, and heart disease, and how to measure it. And that third bullet there, LPS, I'm going to spend just a little bit more time on because I think it's probably one of the more relevant points of my talk tonight. And then finally list 2 diet, lifestyle, or supplement interventions that may support cardiovascular health. So I always like to start my presentation with just a little bit of a review on what systems biology is. It might sound kind of obvious because it is a term that's used a lot. But I sometimes think we take it for granted too. So systems biology is very interesting to me because it's really a discipline in the whole field of biology. It's not just with humans, it's with any biological system. And it's a reminder that the whole is greater than the sum of its parts. So in all of biology, and of course we're talking about in humans, none of the systems work on their own. They're always in communication in order to maintain homeostasis. And hopefully to prevent disease and maintain health. But if disease is there, then they're still always communicating to try to get back to some kind of homeostasis. And you're going to hear me refer quite a bit to what I call structure and function, which is basically anatomy and physiology. So structure is anatomy, right? And function is physiology. And most of the time, function is sort of built or dependent on structure. And that's kind of the great, I think, innate way of the human body. And the wonderful thing about all of this in systems biology is that nutrition is involved with every system in the body. And I think this places dietitians in such a pivotal position to have a huge impact in really every discipline in medicine. And so I also have another kind of perspective on systems biology for you to think about. And that is that some systems of the body are more vocal than others at times. And the 2 systems we're talking about tonight, the GI tract and the cardiovascular system, the GI tract, and there may be many digestive experts out there, I think you can attest for, the GI tract is pretty vocal, right? It gives us lots of cues when things are not right. The cardiovascular system, on the other hand, tends to be a little quieter. Not always, but for many people, it doesn't give out the loud noise that the GI tract does until an event occurs, until someone has a heart attack or a stroke. And so that doesn't mean the cardiovascular system is not giving us information. We just really have to know what to look for. And that's true of all of the systems in the body. We just have to know what to look for. And this starts at the gene level and works its way up through our molecules and cells and systems. And then, of course, those organisms, my little picture of the organisms there, the gut microbiome adds a whole other interface of communication. And one of the things I just wanted to make of note in terms of systems biology too, that we can kind of forget a little bit, is that, traditional medicine is based on disciplines of systems, right? There's neurology, cardiology, the GI. I kind of think of the primary caregiver, internal medicine, the family physician. I kind of think of them as almost traditional medicine systems biology specialists, because they're really dealing with all of the systems, and then referring out if they see the need for any specialty. Okay, so what I'm going to do now for you is just do a few reference slides on the GI tract, and then just a few reference slides to give you a frame of reference on the cardiovascular system, and then pull them together and give you some very strong examples of associations between these two systems and why the GI tract is so important to cardiovascular health. So one of the things that I think you can see right away from just the GI tract is how sophisticated a system it is, just because it's got so many darn parts to it. So I've listed 9 parts here. And I think this is pretty cool because it's almost like systems biology within systems biology with the GI tract. All of the organs, they have to be communicating together for it all to work well. And again, structure and function. And so in my course, we do take a little bit of a deeper dive into each of these organs, but the digestive tract is a pretty sophisticated system. And I refer to some characteristics, I kind of like to call them the key ingredients of the GI tract. And we're going to focus just on 4 of them tonight. I'm going to briefly go through them for you, but there are really 6 key ingredients of the GI tract of why it is so important to the health of the rest of the body. And I know many of you might know this, but I might encourage you to try, and you might have your own way of doing this as well, and that's wonderful. I think it's important for us to be able to communicate this information, though, to other clinicians that might not be as much in the know, and because this is complicated information. And so I have sort of just compartmentalized it into what I call, it's really 6 ingredients I'm showing here, and we're going to talk about 4 with the heart. But the GI tract, it's got, and there's no particular order here, but I'll just go through them quickly. It has, of course, all of those gut organisms that live in it, all of the immune cells, gut permeability, access to the circulation, and then number 5, the endocrine. It's the largest endocrine organ in the body. It produces hormones such as gastrin and cholecystokinin, and actually those organisms produce metabolites that have hormone-like effects in the GI tract and throughout the body. And then lastly, they're the enteric nervous system, which is through the gut-brain connection through the vagus nerve. And so I'm just going to take a quick walk through the 4 key ingredients that are more connected to the heart. So the first one is the gut microbiota, of course. And I know many of you are becoming more familiar with the gut microbiome. We refer to it, the word you'll see in the literature regarding the normal flora is often called the commensal flora for normal flora. And it's very normal to have some pathogenic organisms in there as part of the normal flora, and of course beneficial organisms. And we just would rather see that circle of beneficial organisms to be bigger, because those pathogenic organisms are more opportunistic and will take advantage. And these organisms are not just bacteria, they also include virus, fungi, and archaea. And these organisms live throughout the GI tract, and the purpose of this slide really is sort of twofold. The first is just, and beyond the scope of this talk tonight, but just to recognize there's, a whole taxonomy of what to call these organisms. Phylum is the largest, species the smallest, and then strain is what you might see on a food product or a supplement that's much more specific, and sometimes it's a number or a letter, and it's referring to that organism as it's been studied in research, usually in connection with some condition. And my second point to the slide is really just to demonstrate that these organisms live throughout the GI tract, and they depend on sort of the structure and function of the location can determine the type of organisms. And we're not going to go into each of these, but it's just important to recognize the environment determines, and the environment includes the pH, right, of these organisms. I didn't have the mouth there, so I just put my little smiley face there. That's supposed to be the oral cavity. And that is part of the GI tract. And the oral cavity has its own microbiome in it. But just a quick example of the difference in the pH in the gut microbiome. In the stomach, the pH is roughly 2 when it's empty, so very acidic, and that has a purpose for it to help prevent organisms from coming in and through the mouth and also coming up from the small intestine. Although we do know people have H. pylori and sometimes other organisms. I've had patients that have had fungal infections in their stomach. And then on down into the small intestine and large intestine. And the small intestine has more organisms, but we hope not too many, because that's when we run into SIBO. And the small intestine is not designed to hold a lot of organisms. It's really designed for digestion and absorption. And the type of organisms, too, can determine some of the pH because of the fatty acids that they produce, the short chain fatty acids. So the really structure and function is really quite a bit a part of the type of organisms and where they're located. So then finally, in the large intestine is the location of the most gut microbiota. And the major phylums are 80 to 90% Bacteroidetes and Firmicutes, and 10% actinobacteria, and less of a phylum called Furokomicrobia. And generally, what you'll see, this has changed a little bit in the literature. I'm always checking it because there's always things that sort of are not consistent with these organisms, because these organisms can change with diet and medications and many things. But generally, these are some of the patterns that we're seeing with obesity and diabetes. Is there's an increase in Firmicutes and actinobacteria and less of the of Bacteroidetes. And in diabetes, which including type 1 diabetes sort of has its own bacterial profile too, there's less of bifidobacterium, fecal bacterium, Akkermansia. And these two actually do some cross-feeding together, which is thought to be a good thing. So if there's less of them, you don't get that beneficial cross-feeding. And also Roseburia. And then overall in diabetes, we see lower diversity. And that's also sometimes referred to as low gene count. So that's ingredient number 1. Ingredient number 2 was all those immune cells that live in our GI tract. And there's a lot going on here in this picture, and this is really a whole course, the immune system in our GI tract. It's sometimes referred to as GALT or MALT. So GALT is gut-associated lymphoid tissue, and MALT is mucosa-associated lymphoid tissue. And it just reminds me of a shake, probably because I like ice cream so much, but it just reminds me of a shake or a smoothie. So there's all kinds of immune cells that are located both within the mucosal wall and in the lumen. And there's immune cells that we don't even know their names. They haven't even really been identified yet, but we know they have many functions, including, of course, identifying pathogenic organisms and helping to attach to them and asserting an immune response. The Peyer's patch here that I am showing on the right is a mass of lymphatic tissue that's found throughout the ileum of the small intestine, and it helps to monitor bacteria populations and hopefully prevent more pathogenic bacteria from growing. And then there's M cells, which are microfold cells, and they sort of help to search out antigens to bring into the lymphoid tissue so a response can be generated. So there is a whole lot going on in this second ingredient with immunity, and it's thought that over 70% of our immune cells live in our GI tract. So the third ingredient is the intestinal barrier of the gut, the GI tract, and this is, I think, the characteristic that dietitians, we should be standing up and cheering for this characteristic, because it's what stands for for our profession really, and absorbing nutrients. This is how our body absorbs nutrients, is through this selective intestinal barrier. It also allows us to develop an immune tolerance and hopefully not an over tolerance, so that we're not reacting to everything. It also is a defense against pathogenic organisms. And as we talked about a little bit just a moment ago with all those immune cells, and also a signaling pathway to the brain via the vagus nerve. And the problem is when that permeability in the mucosa wall becomes excessive. And this has been a pretty big learning curve, I would say, in the digestive medical research of what is excessive permeability. We're going to talk a little bit more about it when we talk about LPS. That's the main marker that I use for excessive permeability is LPS antibodies. But you can also measure the protein antibodies, actin. You can measure zonulin antibodies. But for our purposes today, we're going to be talking about LPS because it is relevant to cardiovascular disease. But as you can see, if that space between this one cell lining becomes too wide, we have greater access to the bloodstream. And that is our next ingredient, is the access to the circulation, which is really, I think, a characteristic that gets unrecognized or just, not as much aware of. So there are two major circulatory systems to the GI tract. And as dietitians, we're probably more familiar with the portal circulation because that's how we absorb nutrients through the small intestine, and the nutrients travel through the hepatic portal vein to the liver. The liver does its thing, and then out the hepatic vein to the rest of the body. And the portal circulation extends right up into the stomach in the esophagus. And I can remember back in some of my hospital days seeing, both as a nurse and as a dietitian, seeing patients with portal hypertension and esophageal varices, which is a pretty dangerous thing. So the GI tract is quite vascular from the portal circulation. There's also the splanchnic circulation, which is more of a general circulation that are three major vessels. I don't have a picture of them here, but there are three major vessels that come off of the aorta. And they supply, the three vessels are the celiac artery in the superior and inferior mesenteric arteries. And they supply blood to the stomach and the liver and the spleen and the small and large intestine and the pancreas. So very vascular part of the body, the GI tract. So just as a wrap up, these four key ingredients, and it would kind of make sense now, I hope, of why the integrity of this is so important to heart health. And we're going to jump to the heart in just a moment. But so the gut organisms, the immune cells, gut permeability, and access to the circulation. So switching gears to the heart, cardiovascular system is not nearly as complicated in terms of its design. It's really only got three components to it: our heart and vessels and blood. And cardiovascular disease is sometimes referred to as cardiometabolic disease. And I actually really like that term because metabolic, to me, almost infers systems biology, and it just infers the whole body. So it really reflects how important the heart is in the circulation to the whole body. And then, of course, you add these gut microbes, and we have a lot more going on. One of the things about the heart that I've always found fascinating is that it really, it's the muscle, the only muscle that's contracting 24 hours a day for us. And throughout my career, I've worked with patients that are really quite different, because in the beginning of my career, I was a sports nutritionist and worked with athletes and worked with military soldiers as well. So, being with those types of people where the heart is really performing under a lot of stress. And then all the way to the other side of the healthcare sort of spectrum as a nurse working with hospice patients. And I really enjoyed actually my hospice work. And some patients just so interesting to me, where their hearts could be so healthy and they could be on hospice care and dying, really. Their organs are failing, but yet their heart still keeps on beating. And it's their heart that's really keeping them alive, longer, potentially even, a day to up to a couple of weeks, because their heart is so strong. So three components. It's really, I think, pretty fascinating about the cardiovascular system. So it's three components to it, not nearly as complicated as the GI tract, but we have our heart, our vessels, and the vessels could range in size from capillaries up to our aorta, and then of course our blood that runs through the vessels that supply oxygen and nutrients. And again, structure and function here are very important. So up until, now traditionally, we've sort of focused on these 5 major cardiovascular risk factors: and hypertension, diabetes, dyslipidemia, obesity, and smoking. And we could probably add many things to this list, because there is a thought, certainly in the functional nutrition world, there's the thought that many environmental things could potentially be a hit to the cardiovascular system and damage the cardiovascular system. But what we're going to focus on, and I really would like to encourage your awareness on, is to be thinking about the risk factor of gut dysbiosis, excessive permeability, gut dysfunction, really however you want to describe it, to be a risk factor for heart disease. And what we're finding in this whole space, this cardiovascular research space in the gut microbiome, is they're doing what they're doing in the other areas of the gut microbiome. But I would argue that there's actually even more information on this with the heart. So they're doing what's called enterotyping, and that's just associating certain organisms with cardiometabolic risk factors. And I love this quote here by the director of Columbia University. It's a quote that goes back to 2012, and it really shows him to be right on the mark, I think, with his prediction. So he states that it's almost a certainty that microbiome-based clinical diagnostics and treatments will be available in the near future to identify patients who are at risk for developing cardiovascular disease. And I'm going to share with you a couple of things at the end of my talk that will demonstrate that I think he was really right on the money. So that was about 8 years ago. So when we look at more specifically structure and function of the cardiovascular system, my picture here on the right, it doesn't really do our body justice, but my purpose is really just to demonstrate the magnitude of the vessels in our body. So I showed you before some of the vessels in the GI tract, but here, we have vessels from head to toe pretty much, right down to our fingertips. And I follow, there's a few cardiologists whose work I really admire and follow, and one of them is Dr. Mark Houston, who is the head of the hypertensive clinic at Vanderbilt University. And this is a quote that he uses quite a bit. Vascular disease is a balance between vascular injury and vascular repair. And inside every one of those vessels, throughout our whole body, is this one-celled endothelial lining. And it's inside all of our vessels and all of our lymph tissue. So it's really throughout our whole body. And I want you to think of the endothelium as really almost like another barrier, similar to the gut mucosal barrier and also similar to the blood-brain barrier. And barriers have a purpose. They are to help maintain the integrity inside the barrier, or whatever it's trying to keep from coming in. So it's there for a purpose to keep some kind of homeostasis and balance. And the endothelium is sort of an interesting structure because it is almost an organ. Sometimes it's described almost as an organ in itself because it's communicating with outside of the vessel to try to maintain this balance, trying to maintain a balance between vasoconstriction and vasodilation, with vasoconstriction being the more stressful state, and we don't want to be vasoconstricting when we don't need to be. But sometimes that is what happens, certainly as vascular damage starts to occur. And so the 3 bullet points here I've listed are ways in which we respond to all of the hits that our body takes. And these 3 responses, inflammation, oxidation, and an immune response, can happen throughout the body. It's not just in the cardiovascular system, but I've listed them here in terms of vascular responses because they apply to the vessels as well. So this injury versus repair is how these vessels are responding to inflammation, oxidation, and an immune dysfunction. And these aren't mutually exclusive events. They're usually all 3 happening, together. Oxidation that's left unquenched or unbalanced is going to lead to inflammation, and usually always inflammation, there's some kind of immune response going on. So let's switch gears again just a little bit, and I want to give you 3 examples of some gut dysbiosis or gut dysfunction and the cardiovascular risk that goes along with them. And I'm just going to run through them fairly quickly. My first example is celiac disease. And this is a review of 13 electronic health records. So it included about 22 million patients And of those 22 million, 24,000 were identified to have celiac disease, and all 24,000 of them with celiac had a higher cardiovascular risk, regardless of age or gender versus the controls. And this was also linked to 1.4-fold increase in risk of stroke, even in the absence of traditional cardiovascular risk. So we've learned a lot from celiac disease, really, about the gut permeability, and really, I think how secondary conditions that can also be associated with celiac disease. The second example is with SIBO, and this is, I think, really sort of jaw-dropping to me. But this was a study out of the Cleveland Clinic a few years ago, and they extrapolated a lot of data from this, but what I'm sharing here with you is just part of it. And so on over 1,000 patients with metabolic syndrome, on 160 of them, they did left heart catheterization and a glucose hydrogen breath test. And for those that were SIBO positive, 46% had fatty liver disease versus 40% without SIBO. Now that was statistically significant, and that might not seem that impressive to you, but if you keep reading here on the third bullet and then my red bullets, it really becomes more profound. So the SIBO positive had an overwhelming higher frequency of arteries affected by cardiovascular disease, 79% versus 39%, and then with diabetes, 40% versus 23%. But then when you probe a little more and you see how, when you add more vessels, how many vessels were involved, with 2 and 3 vessels involved, the SIBO incidence jumps to the 80% versus without SIBO, 14 and 18%. And to me, this is astounding. And it asks a lot of questions, certainly, is, are we identifying SIBO? Are we maybe treating it and then it comes back and not identifying it? And I think more research, and I haven't been able to find a lot on whether or not, I think we need to really target research on looking at some of these cholesterol and cardiovascular markers after SIBO has been treated. I know anecdotally in my practice that I have, I'm jumping ahead of myself a little bit, but you'll see what I'm talking about as we get into this next section. But some of the cardiovascular risk goes down. We've checked certain biomarkers after the SIBO's been treated and they have improved. But it certainly is a big area in medicine because I think the research is becoming clearer that SIBO poses a cardiovascular risk. Then my third example here is just kind of a cool study that they did on people who had hypertension and a dysbiosis associated with that hypertension. They were believed to be associated. They had Prevotella and Klebsiella, an overgrowth of, and they did fecal transplants of these gut microbiota into mice, and lo and behold, what happened to the mice? They developed hypertension. And then I also just wanted to include here a study that shows the relationship between potentially heritability and visceral belly fat and obesity. So this is the largest microbiota study to date that shows that there is, with certain phenotypes of abdominal obesity, some heritability with the firmicutes and the actinobacteria. And of course, we know these organisms can change some with diet and other factors, but there is thought to be some heritability with some of the phylums. So how do these organisms do this with the GI tract? What is going on? There are multiple pathways of things going on, and obviously beyond the scope of my little talk today. But what we're going to focus on for a few minutes is LPS, because it's one of the areas that has the strongest research with it in demonstrating the risk for heart disease. And the other thing is just that many of these pathways, of course, they're not mutually exclusive. There's a lot of things going on, not all of them necessarily, but some of them are going on at the same time. So just to sort of set the foundation of what we believe happens before I get more specific with LPS, is just to know that we believe if there's more of those pathogenic organisms, that they can lead to increased gut permeability and endotoxemia in the blood, and then that sets off a pro-inflammatory pathway of cytokines and an inflammatory response. The inflammatory response starts in the lumen of the gut probably too, but also then continues in other cells. And this is combined with our genes, the bacteria's genes, and then other variables of our diet and medications, environment, and then leads to insulin resistance, metabolic syndrome, type 2 diabetes, fatty liver, and heart disease. And there are, all those little circles that I showed you with a couple of previous slides of all the different pathways that these organisms are working through. We could probably very broadly narrow them down into these three categories, but they're doing them through different mechanisms, but oxidative stress, inflammation, and energy balance. And we're going to focus right now just a little bit more specifically on inflammation and LPS. But also just to know with the energy balance, what I'm referring to there is that some organisms have the capacity to change the way in which the host responds to calories. So they can make it so the host is more energy efficient or not as energy efficient. But let's talk a little bit about LPS. So LPS stands for lipopolysaccharide, which is the major cell wall component of gram-negative bacteria. And it's normally present in low concentrations in really all of us, because we all have some gram-negative bacteria. But it's thought to be what's called an endotoxin, because it gets into our endothelium and in that endothelial lining and can do its damage. It's referred to sometimes as what's called a PAMP. It's an acronym for pathogen-associated molecular pattern. And PAMPs are organisms that our body, recognize as pathogens, and we assert an immune response to bind with them as a protective mechanism. So our toll-like receptors bind with these PAMP-type organisms to help protect us. So here we have a commensal bacteria, like a gram-negative bacteria, activates our toll-like receptors. And the key point here is that we have toll-like receptors throughout our whole body. They are in our immune cells, so like our macrophages, they're in our fat cells, our hepatic Kupffer cells, and of course our endothelial cells. And just to keep in mind that picture of all those vessels that go from head to toe in our body. So we have this LPS endotoxin activates an adaptive and innate immune system response, and macrophages influx into visceral fat cells. This is just one pathway that occurs, leading to systemic inflammation. And this stems initially from these toll-like receptors being activated by LPS. And here's just another perspective on it. So increased gut permeability increases absorption of LPS into the bloodstream, activates our toll-like receptors, which are located throughout many cells in the body. And two of the major things that occur from that are impaired insulin signaling and altered fatty acid metabolism in the liver. And here's just another perspective on it, so you can have another visual. LPS, gram-negative bacteria coming through excessive permeability into the bloodstream. Those toll-like receptors in various cells in the body, in the liver, inside the vessels, or in our fat cells, initiate an immune response, which then potentially sets off a cascade reaction of other immune responses, including pathways such as NF-kappa B, tumor necrosis factor, and other cytokines, which are mediator cells, response cells in our immune system. So that's that part, which is, I think significant, but I'm going to shift to just a slightly different topic in how LPS affects cholesterol. So in circulation, 80 to 90% of LPS, as an endotoxin, remember, is bound to our lipoprotein cholesterol called LPS binding protein, LBP. And our body, again, it does this to sequester it, to sort of protect us against it because it's an endotoxin. And so LPS now induces endothelial cell damage, plus it oxidizes the LDL cholesterol. And the research is pretty clear that the highest LPS levels in the blood also have increased atherosclerosis, including carotid atherosclerosis and other cardiovascular risk factors. And what happens too with elevated LDL is that it signals the body to actually make more LDL. So inflammation is a key regulator of LDL metabolism. The good part is if you have good reverse cholesterol transport, HDL helps to clear this some from the circulation. But what's very interesting here is that when you go back in the literature and you really see how some of this has come, how we've learned about this, is that the older studies show that septic patients have markedly elevated LDL and VLDL levels and lower HDL. And this is actually coined lipemia of sepsis. And when, sepsis is a very dramatic, serious state when the body is shutting down, and you can lose organs, you can die pretty quickly from sepsis, and it can accelerate out of control pretty quickly. And one of the things, you're not exactly concerned about cholesterol at that point in time, obviously, but these are observations that have been made of patients that have been septic. And the old school of thought was that this was just some kind of general host response. But now we know that it's a little more specific, although it's an innate response, which is not really specific, but it's an innate response, really very targeted to help protect against this LPS binding protein. So the body's purposely trying to increase cholesterol to help bind off and protect us against this endotoxin of LPS. So this is happening, we think now, on a different scale, though, with many people that have diabetes and heart disease. It's just sort of a subclinical level of LPS. And there's more studies that are showing this, but I've always liked this study because it was done on a broad range of age ranges and over 7,000 people, and they were followed for 10 years, so age 25 to 74. And they showed that LPS had a significant positive correlation with CRP, cholesterol, triglyceride, and a negative correlation with HDL cholesterol. And these are levels of LPS that are, much lower, obviously, than a septic person, and roughly around 2 PGs per ml. Now, they're not going to measure LPS like this unless it's in research or doing something else. In general, when we look at LPS, it's more the LPS antibodies and whether they're present or not. But this is just sort of a perspective on how we've come to really realize of what LPS does and how it attaches to cholesterol, and why its presence is thought to increase cardiovascular risk. And I know Katie knows this very well about me, my thing with insulin. So one of the things that I really is a bit of a pet peeve for me is not having practitioners or other parts of medicine check insulin enough, because insulin can become dysregulated in a variety of conditions. It's not just somebody that's obese. It could be somebody that's thin, that has SIBO, that could have their insulin get dysregulated. So I'm very adamant about trying to get a fasting insulin level on many of my clients. Most of my clients I try to, because excessive insulin drives inflammation. And it's an anabolic hormone that promotes glucose uptake in the muscle and adipose tissue, promotes lipid synthesis and some protein synthesis. And so I really encourage you to try to check fasting insulin if you can with fasting glucose. Encourage your patients' doctors to check it. It's really not an expensive test, and it helps give a much more functional marker of what's going on with the pancreas than just fasting glucose or even just A1C. So this just lastly here, before we switch to another topic, I just think is another interesting study with insulin and the gut microbiome. It's a little bit older study than 2012, where they took pregnant women who had normal blood sugars, normal microbiota, did fecal transplants into mice in the first trimester, and nothing happened with the mice. They remained normal weight, no insulin resistance. However, the women in their third trimester that developed gestational diabetes and altered insulin regulation, and they had altered microbiota, when that fecal transplant was done into mice, look what happened to the mice. They became fatter and they had insulin resistance. So a lot of evidence to suggest these organisms are related to a dysregulation of insulin. So I want to just make a quick mention of fatty liver disease. This is, you know, another whole area that we could talk about much longer, but it's important to just recognize because there's just so many people that are starting to have it. It wasn't even really described in the literature very much prior to 1980. And almost half of Latino population has fatty liver disease. So that's a population of people that really needs more attention with this. Fatty liver disease is basically liver metabolic syndrome. It's greater than 5% fat in the liver without alcohol or other liver disease. Up to 80% of diabetes have fat in the liver. It is an independent risk factor for heart disease. 75 to 100% in populations with pre-existing metabolic conditions. And then there's NASH, which is a continuation of when it really progresses, which stands for non-alcoholic steatorrhea hepatitis. And those liver cells become fibrotic. So it's not a good place to be with NASH. It increases cardiovascular mortality by 300%. So raising the overall mortality of fatty liver disease by 70%. And why is this relevant to the gut microbiome? Again, back to structure and function. Portal circulation's role, the liver gets 70% of its blood from the intestine. It's close anatomical and functional relationship between the gut and the liver via the portal circulation. So the liver is very vulnerable to gut dysbiosis, and I encourage people to check liver function tests. The three main ones I like to check are AST, ALT, and GGT. GGT sometimes is not checked. That's gamma glutamyl transferase, and it actually is associated. There's some interesting research with GGT being related to blood sugar and blood pressure. And so keeping GGT within normal limits, of course. And then just a little bit here on, because we're with Epicure and the focus on low FODMAP, I just want to introduce this kind of interesting information about fructose in the gut microbiota. So fructose, of course, being a FODMAP sugar. Back in the day, some of you might not be old enough to know this, but back in the day, even sort of back before some of my time, I remember a little bit of it. But fructose was actually used as a method to lower blood sugar because glucose raised blood sugar so readily into the bloodstream. Fructose was part of a diabetic diet to lower blood sugar. And now, of course, the research, and we've learned so much more about fructose and it being a FODMAP sugar, and the source of fructose, of course, is important, whether there's nutrients attached in fruit, right, to the fructose, and not all fruit are alike as to the composition of sugars, fructose versus, the amounts of fructose and glucose. But fructose from other sources in particular, so fructose corn syrup and other sources and not so great foods, can change the fatty acid content of the gut microbiome and thought to contribute to fatty liver disease. So for most of my patients, I obviously try to help them cut down on much of the fructose that are from not great sources. Sometimes though, with patients that eat a lot of fruit, we have to cut down some of the fruit as well. Somebody that might be eating 5 or 6 servings of fruit a day, it might just be too much fructose. So interesting how we are sort of very targeting a lot of nutrients and how they affect the gut microbiota. And just a little bit of summary here of the microbiome of type 2 diabetes. Generally, we're seeing lower microbial diversity, depletion of that Ascomycetia, mucin-producing goblet cells, fecal bacterium, depletion of short-chain fatty acid butyrate, which is thought to be a positive short-chain fatty acid protective to the colon. There is research actually on butyrate where too much butyrate might be related to weight gain in some people. So all of this is in balance and very individual, I think. And then the endotoxemia of LPS, which we discussed, and to be aware of chronically elevated insulin levels. So how does this affect all of you, and how can you really use this information in your practice? And the first thing is really just to recognize the connection. just to be aware of these two systems and the association between them. And I love this quote that says, the key to keeping your balance is knowing when you've lost it, because this is really why patients come to see us, is they know they just don't feel quite right. You know, sometimes they can't really articulate exactly what it is, or sometimes they know exactly what's off. And if you look at these symptoms here, you might not usually associate constipation with high blood pressure, or GERD with elevated blood sugars. And so I encourage you, if you have someone that's coming to you to see you that has primarily a GI for GI reason, whether it's celiac disease or IBS, to do a full evaluation of their cardiovascular history, and vice versa. If they're coming to you for high blood pressure or hyperlipidemia, to really evaluate their GI tract, because there is a very close connection here. And I think we could, you know, it's not that far on a limb to say that SIBO and certain dysbiosis is a risk factor for heart disease. So let's talk about something that's a little more positive, that it's not just all down information about the gut microbiome. There are benefits to having a healthy gut and a healthy balance of organisms. And it's really just the opposite of the other slide that I showed you. So if we have a greater amount of those symbiotic organisms that are more beneficial, then it's thought to have more optimal gut permeability, less endotoxemia, so less LPS, and fewer of the beginnings of the whole inflammatory cascade that can begin, and ultimately, hopefully, result in less insulin resistance, improved insulin sensitivity, and less metabolic disease and less cardiovascular issues. And this can be done from a dietitian standpoint. What can you do? The good old Mediterranean diet is really the starting point, I think, for many of us. And as Katie had said in the beginning of her introduction, that Epicured does a wonderful version of With a Twist, the Mediterranean diet with a twist. Everyone can have versions of this. But what I want to point out here is that, you know, I can remember in the beginning of my career, the Mediterranean diet was really the main diet for heart disease. It's probably the most studied diet with heart disease, aside from the DASH diet. And back then, we really didn't know. It was a big deal just to say less inflammation in the body, or even the word inflammation was thought to be, you know, really progressive. And now we've really been able to target that. We think why the Mediterranean diet is so beneficial is really because of its effect on these gut organisms, through all of the, you know, the components of the foods that are in the Mediterranean diet, the phytonutrients, fibers, resistant starches. And this is just one example here that I've listed on the right. One of the primary paths for the rise of glucagon-like peptide might be, we think, carbohydrate fermentation with the appropriate foods, actually in the small intestine, where we actually make our own GLP-1. So, you know, it would be nice if we didn't have to take GLP-1 as an incretin mimic. It's a drug that's used quite often for people with type 2 diabetes, but we can actually make our own GLP-1 by fermenting certain carbohydrates. And then there are other things that are going on with these foods in the Mediterranean diet that are very beneficial in helping to protect against heart disease. So they really coexist, these organisms, the right organisms, with the foods that are in the Mediterranean diet. And a couple of things that are going on here are, one, they're inhibiting pathogenic bacteria and stimulating the better bacteria, so sort of behaving like a prebiotic. And they're also transforming the polyphenols into metabolites that our body is able to utilize better. So they're increasing the bioavailability of the polyphenols. And then thirdly, they're suppressing molecules related to inflammation. And this is something that, you know, we really weren't able to identify as precisely as we have more recently. But they help to suppress vascular endothelial growth factor and intracellular adhesion molecules, which are related to some of the NF-kappa B pathways and some of the cytokine cascade. So the Mediterranean diet has, I mean, these foods just really have, I say, a pharmacological effect really in helping to protect the cardiovascular system. And then this is just a quick slide here. I won't go into this too much, but I'll answer questions, you know, at the end if there are any. The role of prebiotics and probiotics. And this is all done in stages, of course. So, you know, a low FODMAP diet is a stage in treating SIBO and or IBS or other GI conditions. And then when there's an appropriate time to add a prebiotic or probiotic. What's interesting about this research, though, it's almost like off-label findings because it's based off of, some of the original research on probiotics was done on the health of the digestive tract, right? And some of the things that we have found are actually the benefits more systemically of what's happened outside the GI tract. And there actually, is a fair amount of cardiovascular improvements that are thought to help probiotics and prebiotics potentially help. And this slide just shows how the paths that help improve glycemic control. And then generally, probiotics and prebiotics are thought to improve microbial diversity, optimize metabolic balance, improve epithelial barrier integrity, inhibit cholesterol, hepatic recirculation, protect those colon cells, reduce the innate immune response activation through competition, and benefit. There's a fair amount of research on probiotics and fatty liver disease and activating that GLP-1 pathway. So finally here, I want to share with you 3 points, 3 areas, I think, of the future of cardiovascular research in the gut microbiome. And I'm going to go into a little bit more, not a lot because of time, but I'll answer questions on the third bullet. But I just want to point out the first 2 for you. And the first one is something that I became very interested in really right when it came out in 2015. I was all over this study because it was actually a time when I was starting to do a workshop. Kate and I actually did a workshop together, and this research was something that was just coming out right before that. And so it was by a company called Day 2. It's from an Israel company. And they have been able to basically demonstrate a bacterial profile in people and how to control blood sugar based on manipulating someone's diet through their carbohydrates, really based on their microbial profile. And what's important, I think, to take away from their research, because they had a larger cohort study that was validated by a smaller study, and then the Mayo Clinic really got on board with their research. And what's important to, I think, take away from it is that they're really the only company to date that has been able to manipulate a biomarker, such as blood sugar, with associating a bacterial profile with the foods that we eat. So they had dietitians that actually worked on their study, and they changed the carbohydrate content of the meals based on the bacterial profiles. So it's a very targeted study, and I think that there's a lot to be learned from it. The second bullet point is fecal transplants, which are not allowed other than in research for cardiovascular disease in the United States. But it is interesting that there is some research there, and there are some benefits from it, believe it or not. So there are some improved biomarkers, C-reactive protein, blood sugar, but of course it's donor and recipient dependent, and the recipient can't go back to not healthy ways after their fecal transplant, or else, all the great gains can be changed. But I think the third more, I think, intriguing change in cardiovascular research is along the lines of some of the fasting research. And it's important to recognize that fasting includes sort of a range of different practices. And I recommend intermittent fasting for my patients, mostly the 12-hour fast at night and meal spacing during the day. However, this type of fasting, the fasting mimicking diet, is a little bit different. And I think it's much safer from other fasting practices that don't require, you don't eat anything, it's just water for more than 24 hours. And the research on this by Dr. Walter Longo is pretty compelling regarding cardiovascular protection. The company that does it is L-Nutra, and they produce, it's like a kit called the Prolong Kit. And there are currently over 30 clinical trials now being done on a variety of conditions based on this fasting mimicking diet. And I think the turning point with this diet is the fact that you are eating, so it lowers the risk, and the food that you're eating has certain prebiotics in it. The first day is 1,100 calories, and then the second, third, fourth, and fifth day are about 750 calories. So it's definitely calorie restriction. and your body goes through several processes. You go into a mild ketosis, and then it stimulates autophagy, which is a beneficial process as well. But they're showing that these benefits to the cardiovascular system are probably better because of the gut microbiome. So you're never starving the gut microbiome. They're still getting some of those prebiotic carbohydrates to help produce some of those short chain fatty acids and things that are helped to be protective. So I think it's a very intriguing area. I've actually done it myself, and I have a select number of patients in my practice who have done it successfully, and will probably continue to do it. So I'm happy to answer questions about that at the end. And then this is just a nice little summary of showing a lot going on in the different pathways in our vessels and our body, and how these organisms promote inflammation and actually protect against inflammation. So my key takeaways are structure and function of both the GI tract and the cardiovascular systems contribute to the relationship of how gut microbes affect particularly our vessels. So to be thinking about that circulatory access to the GI tract is really very important. LPS contributes to subclinical endotoxemia and is associated with insulin resistance, metabolic syndrome, and fatty liver disease. The unique individual tolerance of carbs and fat, quality and quantity depending on, we didn't get into this quite as much, gene SNPs in the gut microbiome, but the Mediterranean diet basically can be modified depending on each person's individual tolerance of carbohydrates and fat. And then, of course, that the Mediterranean diet provides nutrient-dense fuel to feed these gut organisms healthfully, and may very well be the reason why they reflect such positive cardiovascular outcomes. Supplements can change the gut microbiome. Prebiotics, probiotics may have positive roles, and then the fasting mimicking diet can lower a number of biomarkers related to cardiovascular disease, including lipids, A1C, C-reactive protein, insulin-like growth factor 2, which I don't have listed here, but really quite impressive. So, and there is my the link again to my handouts in my course if you're interested in being on the waiting list, and I'm happy to answer questions, and I thank you very much.
Okay, thank you, Cindy, so much. That was terrific. Really, it's just amazing, the connection, and we're not really talking about it that often,
I know we don't talk about it as much. And
so I'm going to
under the radar. It's really under the radar, which you'd think it would be more on the radar, being heart disease being the #1 cause of death for people. But it's not quite as, I don't know, there's not something about it that's not as, dare I say, sexy as talking about like other, the gut-brain connection or other things.
Absolutely. If anyone has any questions, feel free to use the chat feature in the Zoom lower bottom panel. I don't think I saw any questions. I think it's really, I just wanted to bring up the whole LPS connection because, when we talk about the low FODMAP diet, for instance, we've seen in some of the research that it changes some of the different types of microbes that are there. And we don't know some of the microbes that reduce are probiotic microbes, and we're not really quite sure the relevance of that. But because of that, we've initiated the reintroduction and try to liberalize the diet as much as we possibly can. But interestingly, and I know there's a surge of research in this area that will hopefully come out soon, they've looked at the role of a high FODMAP diet having an impact in increasing LPS.
Oh, I could totally see that. Yeah.
Yeah. So, and they did that in a rat study, and they did find that a high FODMAP diet increased LPS. So I think, when people think of FODMAPs, obviously some of them, like fructose, to your point, right? Those types of, some FODMAPs will have this potential effect on this pathway that you've been beautifully described. But then you also think of FODMAPs like onion and garlic and fructans having a positive effect on the gut microbiome. So I really want them to figure out, are there, for different people, perhaps the low FODMAP diet may be beneficial to the LPS, and not just from the fructose, but maybe there's some other.
Right. It's all about balance, right? It's that there's a balance of, and I think to your points, it's probably, I'd like to see a little bit more testing of LPS antibodies, because I know the testing that I do in my office, not everybody has LPS antibodies. So they'll have positive actin antibodies or other that are supposed to be related to intestinal permeability. And I believe that that may reflect excessive permeability, but I don't put quite as much credence into it, I guess, as I do with the LPS, just because not everybody, almost everybody that I've had checked, because it's in the same panel, will have actin, and not everyone has zonulin positive, but many people have a positive actin antibody, but not everybody has the positive LPS. And I think that that's more sensitive to demonstrate the cardiovascular risk. And it is interesting to see, you know, there's so much work to be done here, isn't there?
Yeah, I think the reality is, in my message and in the science that I've followed, this, like you have, this whole gut microbiome science, is that it's much more complicated than we initially, or if you know a little bit about gut microbiome, you're like, oh, you know, it doesn't seem that complicated, but it's extraordinarily complicated.
It is.
It's not just about who's there, it's what they're doing, it's what genes they're turning on, it's so many factors.
And the metabolites, I think we've said that for so long, it's those metabolites, I think some we haven't even identified that they produce, that have effects, you know, throughout the body. And especially the vessels. I think the vessels are, because there's such close proximity to the gut, that we forget that they you know, sort of have the secondary effects.
Absolutely. And I think, you know, it's really, dietitians are going to be on the front line. They should be really following this science closely. It's not going to be a one size fits all approach. You know, different foods work well for different people. But these gut bacteria play a huge role, right? And in our complete body, not just our gut.
Right, from mouth all the way down.
Right. And keeping that healthy and feeling right will play a role in other chronic diseases, right?
That's true. That's absolutely true. This is just one piece, the cardiovascular piece, but we know it's connected, the gut microbiome, to, you know, the rest of the body, really, the brain and autoimmunity, and there's really so much to learn.
Exactly. So I think, you know, we've gone over, you did a fabulous job. Thank you so much for your time, Cindy. I'm sure that everyone learned quite a bit today, this
You're
evening.
quite welcome. I thank you for the invitation.
Yes. And, you know, certainly if you have additional questions, attendees, feel free to pass them along to us, and we'll do our best to answer them. And you will be getting an email follow-up with additional information from all of us at Epicured. And thanks again for attending, and have a great night, and hunker down and be safe, everyone.
Yes.
Absolutely.
Hang in there for the next couple of weeks, everyone.
That's right.
Yeah.
Thanks again, Cindy.
All right. You're welcome. Thank you. Take care, everyone.
Bye-bye.
Bye-bye.